One of the other treatment modalities to care for patients with fractures is traction. Although traction has fallen out of favor, I think there are a whole generation of nurses who really never have had to deal with traction because we have better ways to deal with it, between splinting and bracing and casting, but really more with the surgical modalities, like internal fixation or external fixator devices. It's really uncommon to see people lingering in the hospital on heavy traction apparatus. Halo traction still used a little bit, or it's really used a lot when you have cervical fractures. And every once in a while you use Buck's traction to immobilize somebody temporarily. It's much less common to see traction than it used to be. But you still see it on NCLEX exams. It's still part of this content, and so we're still going to cover it. The purpose of traction is to reduce muscle spasms and pain. Okay, so obviously, if you are pulling on that muscle, you're keeping it long, it keeps it from contracting involuntarily. It's also going to keep those bone fragments in alignment, or the whole long bone in alignment. Now, if you're using traction as a treatment modality to heal fracture, it can take 6 weeks. And you can see the obvious drawbacks of having somebody in a bed for 6 weeks with limited ability to turn from side to side. But it can maintain the alignment of the bone fragments. So if the doctor has reduced the fracture and casting is not appropriate, traction can be used, especially like pelvic fractures, things like that, where it might be difficult to use an immobilization device. If you can't operate on that patient, Buck's traction will help you maintain alignment. It also can be used to correct and prevent deformities associated with fractures. When you have, say, malunion or non-union, traction could be used to correct those. However, again, much less common. Now, there are 2 types of traction. Let's see if we can move that out of the way, and I'll make that a little bit bigger. There is skin traction, and skin traction uses a device that is external to the patient. So maybe you have a boot, or you have a brace, or you have something that attaches to the traction apparatus, and it pulls on that device. It doesn't pull directly on the patient. So the patient's skin should theoretically be intact, especially if you're checking for skin integrity and intervening to keep it intact. Skeletal traction, on the other hand, has pins that go through the soft tissue and the bone, and they connect to the traction apparatus. It goes through a frame. There is a picture in your book on page 1113 of a balanced suspension skeletal traction with a Thomas splint, and that used to be a fairly common thing to see. Skeletal traction works better for fractures that need a lot more weight to maintain traction. Skin traction can only use like 5 to 25 pounds of weight. Skeletal traction can use more. However, skeletal traction goes through the skin and creates a portal of infection, or an entry portal for infection. And you can get osteomyelitis as a complication of skeletal traction. And so skin traction you may see periodically. I checked with the nursing supervisor at Capitol Health, who's a friend of mine, and she checked with some of the ortho nurses at Regional and at Hopewell. And what she was told is that every once in a while they use Buck's traction, and she confirmed that. She said she has to always find the equipment, and it's difficult because it's not used commonly enough for anyone to ever put it in the same place. So occasionally, if you can't get a patient to the OR for one reason or another, you may have to put them in some type of skin traction to keep the bones in alignment and to prevent muscle spasms. However, a Cochrane review in 2012 showed no significant benefit to temporary skin traction prior to open reduction internal fixation. The evidence is really out. It's from one doctor to the next, you'll see different practices. However, it may be used where you work, and so it's important to cover it. And skeletal traction, as I said, has fallen out of favor to some extent, although you do still see for cervical fractures of the neck, Crutchfield tongues or halo traction devices. Okay, so now let's talk a little bit about what makes traction work. And for traction to be effective, here, let's just set myself up here. For traction to be effective, the main thing is that it has to be continuous. So the bottom line is, don't interrupt the traction. So you saw, I don't know if you saw, but if you look at pictures of traction, and I'll show you some in a little bit, and I'm also going to have a small movie on the next slide that plays, it's about 7 minutes long, and it shows you how Buck's traction is set up and how it's used and how you maintain it. But the basic thing is that there's a system of weights that have to hang freely. And for this reason, I mean, if you ever interrupt the traction, your patient is likely to get muscle spasms and pain, and you might interrupt the healing. You might throw the bone fragments out of alignment, and now you've really caused more harm than good. So if you get a test question that asks you what the nurse should do, and any of the choices have to do with putting the weights on the floor so that they're not actually hanging, putting the weights on the bed, detaching the traction apparatus so that the patient can move or use the fracture pan or whatever it is that they're asking you to do, it is wrong. You never interrupt the traction. That is not a nursing measure. The physician may decide to discontinue traction, but that's really up to them. And I think maybe the one exception to that is if you have halo traction, sometimes they want you to have wire cutters available so that if you have to perform CPR on the person. But in that case, most of the time, effective traction can be maintained. And in a life or death situation, if it's a choice between stabilizing the fracture and getting them to breathe, remember it's airway, breathing, circulation before we do anything else. However, most test questions don't get that tricky. So generally speaking, you never, ever, ever interrupt traction. You especially never detach anything from skeletal traction. Skin traction, you may have to remove the extremity from that boot, that foam boot, and again, you'll see the movie, it'll make more sense. In that case, you're going to have somebody with you who maintains traction on the limb, so you're always maintaining traction. So traction must be continuous. Skeletal traction is never interrupted. Never, 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 never. And I kind of hope you got that message. So, weights are not removed. Any factor that might reduce the effective pull must be eliminated. So, if, let's say the patient wants to put their foot up on a pillow and that pillow interrupts the that pull on the rope, that would be incorrect. Okay, so ropes have to be unobstructed. And what they mean by this, sometimes you have to tie two ropes together to make a long enough rope to go through the pulley and hang on the weight and have the weight hang freely. If you have a knot in the rope, you have to make sure that it isn't anywhere near that little wheel, that little pulley, okay? Because what's going to happen is you're still not going to get that effective pull, okay? And the body has to be in good alignment. You can't have them cockeyed. They can't be shifted to the side. One other thing that I will tell you is that in many cases, counter traction should be applied. Okay, and what that means is that you have pulling from, let's say it's Buck's traction, and there's a weight that's pulling on that lower extremity. If you don't have anything pulling on the upper part of the body, or you don't have anything that keeps the upper part of the body on the bed, you're just going to pull a patient down towards the foot of the bed, and you're not going to get effective traction. So, what you might want to do in that case is to elevate the foot of the bed so that the upper body is lower than the lower extremities, and that pulls from the other direction. So you have pulling from the weight at the foot, and you have pulling on the proximal part of the lower extremity, on the femur and the lower extremity from above. You're pulling from the torso, the trunk. The body weight is maintaining counter traction. And this all seems really complicated, and it sounds like physics, but really I think that the video that I show after this is going to make more sense. But those are principles of effective traction. And so I'm just going to move on to the video part. So Buck's extension traction is a type of skin traction. It is probably the most common type of traction you will see used temporarily. I will show you the video in a minute, which makes it make a little bit more sense. But this picture kind of shows it too. Make that a little bit bigger. There's a foam boot, and that foam looks a little like an egg crate mattress. Those of you who've ever seen one of those, it folds around the leg, and then there is usually a loop at the bottom where a rope can be attached. You tie a little knot in there. It goes around this pulley. Let me show that. Usually there's a frame on the bed. This is a very simplistic drawing, but there's a frame on the bed, and there's a pulley. And you thread that rope through the pulley and attach the weight, and the amount of weight is ordered by the physician to that rope, and that applies traction to the extremity. You can see this is not a skeletal traction. There's no pins, there's no anything going invasive through the skin. And the video will show you how to apply counter traction. The one thing that I want to alert you to is that she refers to the 7 P's throughout the video. And really there are 5 that we are concerned with. 5 is what your book teaches. 5 is what the NCLEX will focus on. She refers to 7, but you can ignore the 7 and just focus on the 5 P's that we've already talked about. The other thing that I wanted to point out is that she talks about putting a TED stocking on somebody. Now, I'm not saying that this doesn't happen, but my understanding is, I put TED stockings on people, and some of you have also. It isn't easy to get a foot that's not fractured or an extremity that's not fractured through a TED stocking. And to do this with somebody who's suffered a fracture, maybe they're edematous, and they're certainly in pain, and that fracture isn't immobilized with anything yet, I can imagine that all that tugging and stretching is going to be pretty uncomfortable. So while we want to be concerned with deep vein thrombosis and thromboembolic complications of fracture, they are common, especially in the elderly, we also want to be mindful of the fact that this might not be the most practical solution. So while you might see some DVT prophylaxis, probably heparin or Lovenox, I would be a little bit leery of putting a TED stocking on somebody whose fracture had not been surgically reduced yet. But as promised, I'm going to give you that video.
Priscilla Williams again. We're going to show you how to apply skin traction and caring for patients in skin traction. I have my Taylor's manual out, scale 9-17, and we'll also do a short thing on skeletal, which is 9-18. All right, the main thing is, again, review doctor's orders, identify your patient, hand hygiene, and provide privacy by pulling the curtain. And I had those curtains open for videotaping. You identify the patient, explain the procedure. Just know before you apply skin traction or skeletal traction that we're treating a broken bone. So always assess your patient's pain level and offer them pain medication or sedation before you give it. So go in and say, hey, this is Mary Smith, okay? And she has a fractured right femur. We have orders for skin traction with 5 pounds of traction. The doctor's order will tell you how many pounds of weight to apply. So I have a 5-pound bag of sand, and the order was for 5-pound bag of traction. So I have that. I have skid traction. Looks like this. It comes in a box. You may have to add the string, but there is a skin traction. You put it on. It used to be called a Bucks traction. You also will need the rope and the equipment. The bars on the end of the bed. Physical therapy comes up and puts the bars on the bed. You don't have to know how to put those on. You need to know how to apply the skin traction with the rope. Okay? So I got my equipment. I have my rope, skin traction, and my weights. The form is still on the bed. I will come in and say, Mary Smith, I need to give you some pain medication, and then apply the skin traction. Bop. I'm a bop her on the head, give her some pain medication, and wait 30 minutes for the medicine to work before I apply skin traction. For benefit of the time, it's been 30 minutes. I'm coming back in the room, got a hand hygiene, and put the traction on. I call this test firing. I make sure my equipment works before I put it on the patient. So I have my boot. I don't want to put it on her yet, but I'm going to make sure it moves freely. So I will set it up where she's at. This is my rope. You have don't forget how to do your slip knot, but you want a firm knot on the end of your boot. You actually tie this string on, and you tie the weight on your rope. See this rope that's frayed? You want to make sure the rope is free of fray. You might want to put some tape on the end of this rope or cut it and get your new rope. Don't want frayed knots, okay? I would need to test fire this, so I would put my rope through the pulley. I need to adjust my pulley, looks like. Yep, sure do. Sometimes I get it put on backwards. I need to just turn it around. This is how we adjust your weight. You want to make sure that this rope is put on in a way that the weight is hanging down. See how the pulley hangs down now? Physical therapy may put it on wrong. If they do, just call them back and have them adjust the weight. Sorry about this for my video person. Okay, now I have my weight hanging down, my pulley. This is my pulley. Your rope goes through the pulley. If you have a frayed knot, you would not want to put tape on it. You get your weight, and you put this rope through here. Some hospitals have a hook that they put on there, and you want to make sure that you do all this before you put the patient's leg in there. Again, remember that little rabbit around the tree thing I do? That's what I'm using. Okay? I want to make sure that my rope goes freely through the pulley. See this? You want to make sure that your weight is hanging free of the bed and the floor, not bumping in the bed, not hitting anywhere, and not touching the floor. So make sure the rope is short enough, but long enough to hang down. Okay? Okay, I'm going to move back up here. My camera's following me. Lay your weight down on the bed, and you proceed to put this skin traction, Bucks traction on the patient. You would have already applied this TED hose. Remember the steps of applying the TED hose. Before they put the stocking on, you need to assess the skin. If they already have a TED hose on like she does, you can pull the TED hose down and assess the skin, wash it, dry it, and pull the hose up. This is all after you medicate. Okay? So I make sure my hose is free of wrinkles. And up there, if they had a fractured femur, I would have somebody hold the leg, put it inside the boot. The heel should be firmly at the end of the boot. And then you want to pull this on tight. Start from the bottom and go over the leg, tight as you can, because this is holding the patient's leg immobile. This is why I said take two people. If you're moving a broken leg around, it's going to hurt. Okay, so then I have the boot firmly in there. And then I just toss this off the bed, right? No. You gently lower the weight. You lower the weight, make sure the rope is free of wrinkles and knots and linen. You want to position this patient at the head of the bed. I'm waiting for my camera to follow me. Make sure your patient's at the head of the bed, top of the bed. Then you want to apply counter traction. If you don't, she's going to slide out of the bed. You raise the foot of the bed. Come on, there you go. You want the foot of the bed raised up slightly so that it applies counter traction. Her body weight is counter traction. Plus, you want to make sure that your rope down here is parallel to the bed. This may not be unless you adjust the frame more. But you need the rope as parallel to the bed as possible. Okay? This rope should be parallel to the bed. Okay? You may have to adjust this bar or call physical therapy. I'm going to get it as high as I can. Make sure your rope, I think, as high as it goes. There is your counterweight. Weight should be freely movable, hanging freely, not touching the floor. Rope parallel to the bed. That's important to know. And you want to make sure that the bed, when you get through, if you lower the bed, the weight is still not touching the floor. You would need to cover this patient up, but do teaching. If I cover the patient, I do not want this linen on the rope. So you cover up one side, and you would take this and tell them, do not cover up this rope. See where I got the linen? Do not put your linens here, they get caught in the pulley. So keep your linens free of the pulley. You also need to make sure that when you do this, after you get it fully applied, come back in every 4 hours, and you want to come back in and reassess this patient. The first thing you do is, I'll put this out of the way so you can see. First thing you do every 4 hours is have somebody hold, and you release these straps and check underneath for any swelling or red marks, pressure areas. So I would hold pressure here, and I would remove this and assess the skin underneath. May pull the TED hose down. May take somebody to hold the foot. Keep that traction going. So when you take the boot off, hang on to it. Okay? So I pull the TED hose down. Look for any pressure marks underneath the straps. Pull it back up. If I had a second person here, they would be pulling for me while I held. And reapply your boot every 4 hours. You also need to assess distal to the traction. So between every 4 hours, I would do the 7 Ps. Every 2 hours.
And so that is the video that shows the bucks extension traction. And the big take-home points from that, if you have pen and paper, you might want to put this on there. The weights have to hang freely. That means your bed linen can't cover that rope. The rope has to be able to move through the pulley. And you want to have counter traction. So those are the big things that you're thinking about. The consequence of interrupting traction, by the way, are muscle spasms. Okay, and that's skin traction. So skeletal traction is a type of traction, and it serves the same purpose as skin traction, except that instead of using an external device, we can go directly to the bone and apply that pulling force there. It requires surgical insertion of pins or rods, and those are then attached to a rope and pulley system that's similar to the one you saw with bucks extension. The advantage of skeletal traction, you can use greater weights. Instead of the 5 to 15 pounds you could use with bucks, you can use 15 to 30 pounds. Obviously, there are drawbacks to skeletal traction. Number one, the patient is relatively immobile. They're on bed rest for prolonged periods of time. And the other one is that there is a portal of entry for bacteria, and the risk is that the patient will get osteomyelitis. So now let's talk about how we're going to help care for this patient. So when we're caring for the patient in a balanced suspension skeletal traction, we want to assess their neurovascular status. Even though they're not casted, they can still get injury to the neurovascular system and compartment syndrome with that swelling. We're going to maintain body alignment. Moving this person can be a little bit tricky. You might need a trapeze or other types of positioning aids. You're only going to be able to move them so far and still keep that limb in alignment, but you do need to take pressure off the bony prominences. Make sure, and this is really important, remember I said you're going to learn to follow the stars. Avoid any interruption in traction. And this holds true for both skin traction and skeletal traction because you can provoke muscle spasm in a patient. So make sure that those weights are hanging freely. They're not resting on the bed or the floor. Don't lift them. Don't remove them. Once they're hanging, leave them there. That's what's keeping traction on that injury. If the weights are accidentally displaced, you're going to replace them. If you can't replace them, call your provider. And make sure that the ropes are intact and that they don't have any knots or fraying or any linens hanging over them, anything like that where the traction might be reduced. And you're going to document on all of those interventions at least once a shift. So one of the other things that we're going to do for the patient in skeletal traction is to perform pin care. And pin care is important with both skeletal traction and external fixator devices. So you'll hear this information repeated. The best evidence suggests that we should be using chlorhexidine solution to cleanse the pin sites. And for that, it's a 2 milligram per ml solution. We use sterile cotton swabs, and you should go around the site from the inside, the insertion site, right where the pin is, outwards in a circular motion. Use one per pin and throw it out and start with another one for the next pin. And a lot of experts have suggested that you leave the crusting, that yellow exudate, at the pin site because it provides a natural barrier to infection. And that, again, is evidence-based practice. Now, where the evidence is not as precise and the recommendations are not clear is how frequently pin care should be done. So you're going to refer to your agency protocol for that. It could be as often as once a shift, or it could be once a day. Showering, or bathing the patient is also at the agent, a matter of agency protocol because there is no evidence to support any particular routine. Now, when you are assessing the pin site, you're going to look for all the signs and symptoms of infection. You're going to look for redness or swelling, and you're going to look for purulent drainage. If you find purulent drainage, of course, you're going to culture it just like you would with any other wound. Get a culture and sensitivity and report that to the physician. Again, the big danger with skeletal traction is osteomyelitis. Obviously, one of the biggest drawbacks to skeletal traction is that the patient becomes prone to all the complications of immobility. And I know we went over this pretty extensively in our basic needs, and now you know why I was pretty intent on teaching you why the body needs to move. The big thing that we want to watch for, obviously, is skin breakdown. Now, the patient who's in traction is going to try and reposition themselves every once in a while throughout the day. The way that they normally do it is to push up on their elbows. They might use the heel of the leg that's not in traction. And so those are big areas for skin breakdown. So really watch the elbows and the heel of the unaffected leg. And you might have to pad those bony prominences with something or massage them frequently. We're also going to assist with our ADLs, and I'll get to that in a minute. But you want to make sure that those linens are pretty wrinkle-free. And I know you're thinking, how do I make a bed when the patient's in that traction setup? And there is a way to do it. You roll the linens from the top to the middle and then have the patient lift up and you take them out the bottom instead of turning them from side to side, and you replace them the same way. We're going to prevent DVT. Usually we're going to use heparin or Lovenox in conjunction with SCDs or TED stockings on the unaffected leg. And we're going to assess neurovascular status frequently, at least every 4 hours. While they're every hour in the beginning because we're looking for compartment syndrome, and then after that every 4 hours to make sure that they're not developing any DVTs. This is a complication of immobility. Another thing you can do to prevent DVTs is to have them do some isometric exercises, gluteal setting, quad setting, so that there's some venous return. If the skeletal muscles are contracting, it helps the blood return to the heart and prevents venous stasis. We're going to try and prevent respiratory complications of immobility, like atelectasis and pneumonia. So deep breathing, coughing, incentive spirometer, all the things we do for patients who are in bed for prolonged periods. And we're going to be listening to lung sounds and assessing them for any compromise. We're also going to look at their GI system. Patients who are on prolonged bed rest get constipation. They have a loss of appetite, and so we're going to address that. We're going to offer them a diet that's high in fiber and fluids, and we might have to give them some stool softeners or laxatives. Now, as far as improving the patient's appetite, if you can give them a selection of their meal choices, try and work with them for things that they like within the prescribed therapeutic diet, because you're trying to inspire bone healing, and you also want to promote normal peristalsis. You're going to steer them towards the healthier choices, but if there's something in particular that they like, it's okay to include those preferences in your meal planning. Now, to prevent urinary stasis, a lot of people really have a hard time using the bedpan, but obviously this person isn't going to toilet any other way. It's important to make sure that they stay hydrated, because people might stop drinking just so that they don't have to use the bedpan. But that hydration is also going to prevent DVT and constipation, so it's important to keep them hydrated. We can use a fracture pan for this patient, and really check with them every so often. A urinal for a male could work. But you're going to look for signs and symptoms of a UTI because that patient is immobile and there might be some urinary stasis. So obviously another big part of our care plan is going to address the self-care deficit that comes with the immobility and dependence that traction can cause. So we're going to promote self-care. We're going to assist with bathing, toileting, dressing, and feeding. All the things that the patient would do for themselves but can't do now. But allow the patient to do as much as they can. If they can wash their own face, if they can wash their own torso, allow them to do that. That's where the use of the trapeze is great. If they can use a little bit of their upper body strength to turn and move and help you take care of them. Position all the things within reach so that, especially their call light, their cell phone, anything that they might need, so that they can reach some things for themselves and they're not always calling for you. Not that we don't want them to call. It's just that you want to preserve the patient's independence. And certainly part of your job here, this can be a really tough thing for a patient to experience. Initially, it's going to seem a little intimidating and frightening to look at all this equipment. And then as time goes on, the tediousness of being on prolonged bed rest can have some serious psychosocial consequences for this patient. So you're in there a lot, helping them with their self-care needs. Use therapeutic communication to decrease anxiety. And the last thing I wanted to call attention to was halo traction. And halo traction is something you might see actually fairly commonly with cervical fractures, C-spine fractures. And I think we've all seen pictures of this in the movies too. And I want you to kind of notice the vest that this girl is wearing. I think we've all seen the halo with the pins that go directly into the head. Pin care is going to be important for this, but really notice, hold on, let me circle this. Right here, there's a wrench that's attached to the vest. And the reason that that wrench is there is that if you needed to do CPR on this person, there's no way you could possibly do it with the traction the way it is. So you can release the traction if you need to for CPR. And halo traction can be intimidating for people. Certainly you're looking at body image disturbance with that. But pin care, and when you move the patient in halo traction, be careful to move them. You know, if you're turning them from side to side, move the entire body as a unit, like a log rolling technique, and avoid putting any pressure on the pins to decrease pain. So that is halo traction.